Hi and welcome to the first episode of our new series, PSS in Conversation. My name is Charlotte Howden and today I'm going to be talking to Dr. Asli Ucyigit, who's a consultant at Epsom and St Helier hospitals. She's going to be talking to me today about a brand new service that they have developed and launched, which is an incredible ambulatory hyperemesis service. Now, if you're watching this video on the first day that we launched it, then today will be International Hyperemesis Gravidarum Awareness Day. And as this year's theme is Hope for HG, I think it's really exciting to be talking about this new service to really give us an example of what other hospitals in the UK can do to help women who are suffering from HG. So I hope you enjoy this first in conversation with. There's going to be plenty more, so watch this space. So hi to Dr. Asli Ucyigit. Thank you so much for joining me today for our first episode of In Conversation with PSS. So it's probably best to start off with, if you can just tell us a little bit about what you do, your role at Epsom and St Helier hospitals, yes. And then we can talk about your incredible new service.
Well, thank you, Charlotte. Thank you for having me. It's a pleasure. I've been really excited about this meeting. So my name is Asli Ucyigit. I am a consultant obstetrician and gynecologist, and I joined Epsom and St Helier just at the end of 2022 as a consultant there. And one of my main roles is co-lead of the early pregnancy unit. So we have two sites. I'm the lead for early pregnancy at St Helier Hospital. I have a wonderful colleague, Miss Nadia Amakran, who I co-lead with, and she leads the Epsom early pregnancy site. So that's the main remit of my work at the moment.
Yeah, brilliant, fantastic. So I hope you don't mind me sharing, but when we actually first spoke, you actually told me that you yourself have suffered from hyperemesis. And I do think within our community, it's quite a theme that whenever something inspirational or big change happens, it's usually because a woman who's had hyperemesis has a platform or the opportunity to be able to do so. And I think I've definitely put you in that same category. So it happens so much. Like when we think about the research that happened in America,
yeah,
Dr.
Triggered
Bezos,
by her own experiences. Yeah,
absolutely. And I think just generally with women's health, it's just not at the top of list of any list really to go, oh, let's go and look at why women are throwing up consistently in pregnancy. And it takes someone to say, no, this isn't right. So would you mind sharing your experience with hyperemesis with us?
Yeah, not at all, gladly. So my first pregnancy, I gave birth to my daughter in 2017, and literally by week 5 of the pregnancy, the nausea and vomiting had set in. And I heard my mum talking about her experiences of vomiting in pregnancy and how she was literally bedbound for the entire duration. But I was optimistic that I'd be able to manage it. I'm a gynecologist. I have amazing access to colleagues and services, but it just wasn't like that at all. It was a crippling, I would say, experience, just lying on the sofa with a bucket by my head, pretty much until I delivered. I lost 6 kilos in the first few weeks of my pregnancy because I just couldn't have any oral intake. And surprisingly, the help, the support I needed just wasn't there. So it was very difficult, obviously, to get a GP appointment. My GP was fantastic, gave me some medications and prescriptions, but it wasn't enough. And the prospect of going to A&E and sitting on a hard chair amongst other unwell people, constantly vomiting, needing to lie down, noise was a big stimulus for me. Any sudden or loud noise would make me vomit. I couldn't bring myself to get myself into that environment and get some IV fluid resuscitation, some IV anti-sickness medication. And I suffered really badly in that pregnancy, along with the stigma that's attached to it. So a lot of people, I don't think people realize that hyperemesis is actually a medical complication of pregnancy. It's not part and parcel of what we would call a normal pregnancy. It's an illness, it's a diagnosis, and it needs treatment. So obviously at work, I would be in clinic and I'd have to vomit in between patients and try and keep myself going. And I just thought, this is not sustainable. I'd be calling in sick a lot. And with that, you'd hear the comments, the remarks from colleagues, oh, it's just a bit of vomiting, you know, why is she being so pathetic?
Yeah.
Comments like that, and they stick with you even now, you know, 7 years later. I haven't forgotten what was said. So it was a very testing 8 months or so. Literally, even in my labor, I was vomiting, delivered the baby, vomited, delivered the placenta, and then I felt like me again. So yeah, it really opened my eyes to the suffering of this condition, and also how there is a real lack of support, understanding, and accessible treatment. Treatment's there, but it's just hard to get to. You need someone to advocate for you.
Yeah, and I think what people will be really surprised to hear is, given your role, given what you do, I mean, you're not just a doctor, you're a doctor specifically that deals with pregnancy, that you would struggle getting that, you know, access to treatment, that kind of empathy as well, so from your colleagues, like you already said. So I think that'd be really helpful for women, because you would just expect, or if you're clinically trained or you're a doctor, or you know the right numbers to call, that you would get this kind of gold standard treatment, but that just wasn't the case.
No, it didn't exist, and in a way it was almost worse. I remember one day I dragged myself in for clinic, vomited obviously on the way, vomiting up the stairs, just felt awful. And I think my colleagues, they were trying to be helpful, but actually what they did wasn't helpful at all. They cannulated me at work, put me in my clinic room, gave me a bag of, I remember it was so cold, that fluid, and I was freezing in that room, lying on the examination couch. So I had a bag of fluids running. They gave me some IV anti-sickness medication. And once that was finished, like, right, back to work, clinic's busy. So I finished the clinic and then left still feeling not great. And I think it was at that point, as I said, you need an advocate. My mum was horrified. And she said, that's unacceptable. You know, you need to go to the GP, you need to be signed off, you need time to recover. So even as a gynecologist with access and understanding and people around me, even then I don't think the appreciation is there that one bag of fluids and a bit of anti-sickness isn't going to cure you. It's just a holding measure. Looking back, actually, in retrospect, you can't believe what you went through and how you were managed and what people's views of you were.
Yeah, and it's really quite shocking, that, isn't it? And I think you're right. I think, you know, the whole perception of this condition is that it's just something you've got to get on with.
Yeah.
If someone does go, oh, okay, well, we will help you a little bit, it's just for 24 hours, like that's going to miraculously cure you, and then you're kind of pushed out. I get it, and it's very difficult to get your head around that.
Absolutely. I also found in my second pregnancy, I was ready. I'd read up on it, and I'd read about steroids and prednisolone. I thought, this time I'm going to be really well. But again, there was no care. So there was no follow through. There was no one ringing back to say, well, how did you find the prednisolone? Should we alter the dose? Do you want to add a different anti-sickness medication? No one took ownership. And that makes me really sad. And I think that was one of the triggers for me. I thought, no, I want to help women. I want to set up a service. I want to lead something where people can come back and access us and bypass all the emergency department steps and the GP steps and come directly to people who want to help you and want to help you for as long as they possibly can. I think that was an eye-opener for me.
Yeah, definitely. And so it's probably fair to say that if you hadn't have suffered from hyperemesis, this idea of creating such a service, it would probably not have come into your mind. You know, you might not have thought about it in that way and had that personal experience to really push it forward.
I think so. I think, as with many things, until you've experienced it in your close personal realm, you perhaps don't develop such a passion and motivation to do something about it. I agree with that.
Do you mind me asking, you know, how is your mental health? Because your first pregnancy, it was the whole pregnancy, pretty much, you said. You were literally vomiting. You know, how was that affected, and how do you think your treatment and your care kind of maybe exacerbated mental health effects or poorer outcomes mentally? I mean, are you happy to talk to us about that?
I think the first pregnancy wasn't too bad. I was lucky because my mum had been through it. She was super supportive, and my sisters as well, my husband, everyone. I had a really good network around me. But the second pregnancy was very different, because obviously when you have the responsibilities of a child to care for, and you are a knockout with hyperemesis, because that's what it is, you are literally out of action for 8 months, you will struggle to care for your child. that was tough. And the feelings of guilt towards my firstborn, the feelings of inadequacy, of being a failed mum, hit me very hard. And I know that's a feeling that resonates with a lot of women. And you know, there's a lot of evidence, there's a lot of studies out there that show that women who suffer from hyperemesis end up terminating very much wanted pregnancies. It's up to 20%. And that's just so sad. And it you know, if we could support people a bit better, if we could just care for them, advocate for them, say, don't worry, come to us, or this is what's available to you, signpost them to the right places, maybe that statistic would change. Maybe women would feel more empowered and less scared to suffer from this horrible condition.
Yeah, absolutely. I completely agree with that. And I think that kind of really brings us on to the service, really. We should talk about that because that's what we're here to kind of highlight, because it's really exciting. And I know that launched earlier in the year. So, but tell us what it's called, what it's all about, how you access it, and what you think this is going to do for women with hyperemesis.
So when I joined Epsom and St Helier, I and my colleague, Miss Amakram, we were very fortunate in that the consultants from the A&E department contacted us and said, you know, we've had this idea, we've been wanting to do something like this for a long time. What do you think about moving hyperemesis care out of the emergency department? And immediately we knew we had found a team who were going to be as motivated as us, and we took that forward. And what we launched at the beginning of January was what we call the ambulatory hyperemesis unit. And the idea and the concept of that at St Helier Hospital is that it's open to everybody. We are very welcoming, doesn't matter what your postcode is. If you are able to get to us, come. But we really wanted to achieve with it was that it was accessible to women. So direct contact with us. So anyone who has a diagnosis of hyperemesis, either from a GP or A&E, or anybody who's had hyperemesis in a previous pregnancy and recognises the same symptoms again, we've found a mobile phone and we've dedicated that number. We just sourced it, and we've dedicated that number. That number is answered every weekday from 8 to 10 by the hyperemesis nurse, who will talk through your symptoms, ask you some questions, and make an assessment of what kind of help you require. If it's that you just need a bit of medication to start off with, we will arrange that for you. And if we feel that actually you sound a bit more unwell than that and you'd benefit from some intravenous fluid hydration and some intravenous anti-sickness medication, we'll invite you in. And we've ring-fenced a lovely space. It's a little kind of, at the end of the ward, we identified a conservatory with put some recliner chairs in there, space for 2 to 3 women, some nice magazines. And every afternoon, every weekday afternoon, we deliver that care and we try and get everyone home by 5. Direct number, call us every day. You can come back every day if you wish. If you need the treatment, we are there for you. That's the aim. And so far the feedback has been overwhelming, actually. The messages we're getting from patients, the comments we've had from staff who've had hyperemesis in the past, who said, I wish this service had been available when I was pregnant. It gives me goosebumps to see the impact it's had on women.
Yeah, absolutely. And I think, I mean, there's lots to pull out there. I mean, I think firstly, really important thing that you said about, you know, try and get those women home by 5, because if they do have children already at home, that's kind of, you know, the time where, you know, I think a lot of women miss out on being around when their kids get put to bed, or, you know, they might not be able to be around when dinner's being served and that kind of thing. So, and I know from my own personal experience, staying overnight in hospital when you've had fluids it's actually it's a bit like torture. Traumatic. Because there's so many noises and beeps and smells, and you know, everything is a new environment and you're not comfortable. And
not at all,
you know,
even the TED stockings. I remember when I was admitted, those TED stockings, I just couldn't sleep. I couldn't sleep with them on your right. The beep, and then the noise, and everything would trigger you and you'd vomit. So again, the purpose of our service is that we can avoid admission to hospital, because actually that's not helping anybody. I don't think the majority of women want to be staying overnight in a bay of other very unwell patients. And actually from a hospital perspective, so a way to kind of get support if you want to establish this type of service is to emphasize the impact it has on inpatient admissions, and not only that, the length of stay for patients. Let's say someone is so unwell that they do need to come into hospital to stay a night. If you have this kind of service available, they can go home sooner because, you know, they can come back and have the day treatment rather than stay, you know, languishing in the corner of a gynecology ward somewhere.
Yeah. And, you know, I appreciate that all trusts operate in different ways, and, you know, a lot of our hospitals were built maybe hundreds of years ago, and so it's not necessarily easy to just establish a new ward. But from what it sounds about your service, for myself, when I think I was coming up to 12 weeks pregnant, they weren't quite sure where to put me, and I ended up in what I called the women's problems unit. So I had yeah, it was insane. Like, it was the spectrum of female health. You know, I had a woman across me who had a hysterectomy, who was an older lady, so definitely I'm not thinking about pregnancy again. Yeah, completely. You know, a woman who'd had an ectopic pregnancy, a woman who had miscarried, and then there's me, you know, hooked up and definitely still pregnant, very much pregnant, and vomiting. And I just felt like this is, you know, and that's when I got the eye rolls from people, because I felt awful. I felt really guilty taking that space in that bed. And you know, the reality is I would have been anywhere else, like literally put me in a closet with a drip, fine, because I don't want to take this space, but I need help too. So I think, you know, it's really, it's problematic.
It just makes you wonder, like, I do wonder how many women don't approach the health service, don't approach anybody for help because of that. You just don't want to be that person. You don't want to be causing trouble. You don't want to give anyone else work to do. You'll just kind of plow on with it. But I think, as you say, if it were less intense, if that environment were a bit kind of more user friendly, as it were, I think more women would make use of it. And I hope they do. I hope anyone who needs help and is able to get to us comes to us. Definitely 100% will do our best to support you.
Yeah, absolutely. Yeah, it sounds like you've really taken away all those barriers that can be there, and there might be just a perceived barrier, like you said, of, oh, I don't want to put anyone out, but a lot of the time, like we've already spoken about, it's I don't want to have to sit on a large ward with other people suffering from something different to me, who don't understand and relate what I'm going through. So what you've set up, you know, you might be in there alone one day, you might have other, but you're probably going to strike up friendships. You might, you know, be able to talk about, you know, what you're going through. So it's really amazing. So I think the obvious next question is, if the healthcare professional, someone who works in maternity services, another obstetrician gynecologist, A&E is watching this, what advice would you give them as to how to set a service like this up? What's kind of your top 5, maybe, you know, nuggets of wisdom to really be able to commit to doing this and then make it a reality?
I think probably number 1 is identifying the key players. So the people who are going to be as motivated as you. And people will have different motivations, by the way. It may not be that they've experienced hyperemesis. It may be that actually they want their emergency department to be freed up of women who sit there for hours on drips taking up a bay. So it's identifying who would benefit in some respect from the establishment of such a service, and then also finding people who feel passionate about it. And, you know, I was really lucky, my colleagues, the nursing staff, so passionate, so motivated, ED, the early pregnancy unit, everyone suddenly, it ignited this enthusiasm. So that's number 1. Number 2, I think anytime you want to establish a new service in hospital, trusts are very keen on data. So one of the things I did was I did an audit. I looked at all the women who'd come to both Epsom and St Helier A&E with hyperemesis, and I looked at how long they waited for treatment, what treatment they had, how long they were in the department, how many were admitted, and how many nights they stayed. And I've done these kind of studies before and published them. And you can present that data to say, well, look, imagine if we had a recliner chair somewhere on the gynae ward with a drip stand. Doesn't cost much to set up. You can usually find that stuff in the hospital. Look how many women potentially could bypass the emergency department, not be admitted, and just have an afternoon of fluids on the ward. And when you present things like that to your trust, suddenly everyone's very excited about it, and you find that extra support and help that you need. So they're probably the two top things I would suggest.
Yeah, definitely. Yeah, I think that's right. And I think, we're a charity, we support women, but we are very much aware of the reality of the NHS and how it works. And pots of money don't just appear to set up services really quickly. But I think you're right in that if there is a problem, and for A&E staff, having women coming through and, having them having to sit and wait for that length of time and being sick in the waiting area, the women don't want that, the staff don't want that. They obviously want to be able to help, but more serious things will come through A&E, as we know. And most women, I think, that we speak to at the charity, they find it that they make the decision of, I really need some help, and it's normally like 2-3 o'clock in the morning, which is probably the worst time to be going to A&E. So that's a problem. This is the solution, and I think when you present things like that, I think you're right, it's quite an attractive thing to look at. And also, I hope for your trust, if they're watching, the big wigs, the people at the top, this is a very, for the hospital, this is a really, really exciting thing, and it really shows your compassion and want to provide a service which makes sense, that's going to help everyone. So that's something that should be celebrated.
There are a lot of kind of ethoses and mission statements put out there by various trusts, but there's always the same recurring theme, and it always is patient-centered care. So really thinking about the patient, what's right for them. And I think especially at Epsom and St Helier, it's about the right care in the right place at the right time. And I think this is a great example of that. The right place at the right time.
Definitely. I love that. That's brilliant. Is there anything else you wanted to let us know about the service? We will, obviously, it's already highlighted on our website for those that are interested. We'll put details about it as well below this video. But just to finish off, is there anything else you wanted to let us know?
Yeah, so I just want to repeat, the service is available to anyone. If you feel like you can do that journey, please come to us, give us a call, go to our website, the phone number's there. At the moment, unfortunately, we can only accept calls between 8 and 10 on weekdays, but hopefully, if the service becomes more popular, that will expand because everyone will see the benefits of it. So yes, give us the call. If you need anything, any advice, any support, we'll be there for you.
That's brilliant. Thank you so much, Asli. It's so lovely to speak to you.
Likewise.
And yes, this will go out and hopefully will reach those women who will need it. And I hope